team. I definitely see you in your roles as part of our public health team. And I have good news to share. We are headed in the right direction. We were placed, if as many of you can remember, we were placed on the county watch list on July 5th. After we call it the Memorial Day breakout, where after people were cooped up for a long time, a series of weddings and graduations and other activities resulted in Marin County having its first, and also just the community presence of COVID-19. It's not all our fault. The virus has something to do with this too. We saw our case rate increase to a high of 281 cases per 100,000 residents. Today, and it might have changed again, but the last time I looked, we now are down to 112 cases per 100,000 residents. And when we get below 100 per 100,000 and maintain that for a consecutive 14 days, we will be off the county watch list, which would allow for all schools to open without a waiver. That all being said, we have, in Marin County, we have exceeded at testing. We are one of the highest counties in testing per capita. We test more than 500 tests are completed a day, if not more than that. And we believe that this is going to position us to a new tier. So the governor tomorrow is going to be introducing a new tiered system, which is similar to what's been developed in other countries for really having a very clear picture where a community is, or in our case, counties are, on the risk of COVID-19 transmission, and having a tiered-based approach towards reopening and or closing activities. So we're expecting more specificity from an announcement tomorrow from the governor, and more specificity to be published on Monday. But we suspect that because of our high testing rates, as well as our strong focus on the outbreak area in the canal, that we may be considered at a lower risk than we previously were. That's all to be confirmed, but I'm cautiously optimistic that we are headed in the right direction, which may mean, and this again is to be confirmed, is that we may be in a tier that even schools without a waiver would be able to open after September 8th. So that's all to be confirmed. The nugget for you is that we absolutely continue to improve and see a reduced risk of COVID-19 transmission in our community, and there'll be much more clarity from the state around a new tiered approach towards reopening and closing county activities down. So that's all good news. That's it for my update. All right, so here we go. Our team, we have an awesome team, and Linda Metz is on the phone. Many of you may know Linda Metz. She's worked in public health for a long time, and then jumped to our detention health ship, but we pulled her back in. She single-handedly reviewed all of the initial waivers, and we're really appreciative of Linda's efforts to review all those waivers. And I guess that's my final update, is that we will be submitting 12 waivers to the state tomorrow to review for reopening schools, our first round of reopening schools in Marin, which would be on September 8th. And so this is our email is monitored daily. It's usually Linda that's answering those emails at covid19schools@marincounty.org, or you can call our regular number and ask to speak to the COVID school department of, it's not just a department of one. Linda's not alone. We also have Marcia Grant, Sandra Rosenblum, and are looking at growing our team in the school space as we get more schools ready to open. But again, we absolutely see you as our extensions. We want to be highly available to you, and we will hear back quickly if we are not. Oh, that's a typo. It's COVID-19, not COVID-10 schools. I just saw that. So COVID-19.
Okay.
It's not 2010 anymore. Maybe we wish it all was. No, it's better now. It's better now than 2010. It might not feel that way today, but we are better than we were in 2010. Yeah, so we want to be highly available, especially in the beginning, which is why we're growing our team, and we want to be we're ready to answer even the calls that you might think are silly and you're embarrassed to be asking a question. Never be embarrassed to call us or email us and ask us a question. There's no silly question at all in this space. And we all learn from the unusual, weird scenarios. We all learn and then learn how to improve our communication and improve our documents to make sure that we all are on the same page. Jump ahead.
Okay, all right, thank you, Dr. Santora. And I just want to say, you know, Lisa, you and your team have been such, you know, great partners through this whole process. I mean, from the very beginning, the first day that the pop-up childcare centers opened up, and you know, and we have had a lot of questions every day, particularly at the outset. And so what we've learned so far through these really kind of 3 phases of operations that has gotten us to today is that we just can't do it without public health's guidance and input. And we know that this has been a dynamic and ever-changing situation, and the guidance changes from the state and the CDC and local health, and we're trying to do our goal is just to do everything that we can to support the needs of our students and families and staff in the best possible way. And so thank you for your ongoing day-to-day partnership, Dr. Santora, and your whole team. So, you know, you can see here just some of the numbers that we've gone through. The emergency pop-up childcare, Dr. Santora and Dr. Willis put out like a 1.5 page advisory on how emergency pop-up childcare needed to work. It's not your standard childcare. It was very specific with distinct cohorts of students and staff. And that's really the model that worked so well. We incorporated it to run our spring pilot programs, and then for our summer programs for our special education and alternative education programs. And can you go to the next slide, Melina? And, you know, so this is, you know, from March 19th to July 31st, this is the experience that we've had. And, you know, through the 3 different phases of the program, we've had a total of 45 cohorts, you know, over 90 days of operation, close to 6,500 student days, and over 1,100 cohort days, a cohort of kids being together with staff for a day. And through that whole process, you know, there were just 2 cohorts that were closed due to COVID-19, you know, positive. And of the 3 positive tests for students, 2 of them were siblings who had a family member who had driven them to school. They were asymptomatic, but they during the health screening let us know that they had been in contact with a family member who tested positive. They didn't live with them, but were driven by them, and so we you know, followed up with tests for them with public health guidance, and then we've also had, you know, two family transmissions, a student and a staff member as well. But Lisa, do you want to say anything else about this kind of overview?
I just think this shows the success of us working together, that we can create safer environments. And this is at, if you see, some of them were in that July period. And I actually think the one child-to-child transmission was before our July surge
Right.
in cases. So even going into a time where there's a higher level of COVID circulating in our community, we have been very successful because we have all of those protection plans in place in keeping COVID out as much as possible, but then showing our rapid response that when we do identify that someone has had a known exposure, that's when we're working with public health to get them into testing as soon as possible to determine if the cohort needs to be closed or not based on potential exposure. And why you did not see one of these incidents actually met definition for an outbreak. So there were positive cases, but there were no outbreaks in our experience here. We have had outbreaks among some youth populations in the community. One was more of a social outbreak of friends who weren't following social distancing or shelter-in-place guidance. So it was a group of friends that had an outbreak, and another one was a camp where kids were being transported together in a vehicle. And it probably wouldn't be surprising that that happens for us, at least, because carpooling is a risk when you're in a car and the windows aren't down and you have people from different households close together. Then you have a risk of transmission. So to me, this really reducing the risk of COVID-19. And what happened in the background of this, and this is where you all will play such a key role, is we were talking to the site, I guess the site lead at each of these sites, and providing day-to-day instructions and guidance to make sure that we did the contact tracing. So identifying everyone who may have been exposed, and then contacting families. Sometimes specifically we're contacting families to get them connected to testing, and providing them with guidance.
Also, we're going to have a repeat of this exact training a week from today at 3:30. So for any of you who are on, if your colleagues or staff have not been able to join the session, know that we'll repeat it and it will be taped as well. So through this process of working with public health in our pop-up childcare programs and spring and summer pilots, we've really kind of created the public health liaison role. And what Lisa described is the case. Every time there was a question, it was Marcia Grant, a public health nurse that works under Lisa, that we were in daily communication as questions came up. I mean, initially there were questions about a staff having a fever or not feeling sick, or there was a temperature check. We actually had a thermometer that was not operating correctly, and we had those staff stay home until we found out that it was a improperly functioning thermometer. But every step along the way, when a question came up, either by text or by phone or by email or by a phone call, Marcia Grant would get back to us and let us know, what steps we needed to take, if any. And then a big part of it, of course, is any time that there was a potential exposure, is communication with the staff and families. And what we see is some of the most critical aspects of the role is knowing the exposure protocols. There's a link here about scenario 1, scenario 2, scenario 3, scenario 4, which we'll go over in a second. And if as the public health liaison, you need to be fluent with those, and then know that every situation has its nuances and might be a little bit different than the described scenario based on what has occurred with that student or staff member or family. And then once there is a COVID positive diagnosis, what public health needs, within a very short period of time, is a list of all the students and staff members from that cohort, their contact information, their parents' contact information, in order to conduct the contact tracing. And so, these four kind of bullets here are the most important parts of the public health liaison role. As the public health liaison, you need to know that people at your site, teachers, parents, students, administrators, are going to come to you with questions, and you're not expected to know the answer to all the questions, but to then forward them to your public health liaison or your public health contact, who will help you answer those questions and get good information out to the group. So Lisa, am I correct? Like, I felt like for myself and my colleague Melina Boyd here, we always had Marcia 24 hours a day, 7 days a week. She was ready to answer our call. Is it accurate to say that every school site liaison will have a point of contact on your team?
Yes. So we will make sure that we have our email, which is monitored daily. We have our number, the 7191 number. We could be contacted at any time, and they would get any school contact in touch with the school nurse on our side, who is managing the contact tracing part of in the schools. So, and again, this is where we'll be growing our team. So as I mentioned, it was Marsha will still be part of the team. Linda's joining the team, and we know we need to grow in this area so we can continue to provide those rapid responses, because that's what builds your, part of it, it's building your confidence. And that's again why there's no bad questions. A lot of times it was just people reading the scenario back out to me as they're reading it, and us saying, yes, you're doing the right thing. Sometimes you just need us to give you a stamp of approval, or there might be a complicated social situation that's making making it harder. You're making what your role feels like a little harder, and we're there to help on that front too. So our goal, and we know this, is getting schools open, and keeping schools open is ensuring that you feel confident and competent as in the liaison role. And we'll hear from you what more information you'll need after today's training, and we'll provide it. And most importantly, I think, is just being available and just brainstorming some quick solutions. And just often, most times our calls were just telling you that, yes, you're doing absolutely the right thing. That was probably the nature of most of our calls. So
That's great. So I'm going to hand it back to you for contact tracing.
All right. So what is contact tracing? So we are taking a different approach in the schools for contact tracing because we are not using in courts the strict definition of a close contact when we're going to recommend testing. And that's because we're acting out an abundance of caution, again, to build confidence in staff and parents and students alike that we're creating the safest environment possible. So normally in contact tracing, a nurse or a contact investigator would identify who that case is and ask that person who they had close contact with. So our definition of close contact is someone that has spent more than 15 minutes without a mask and has been less than 6 feet away from a COVID positive person. The conditions that we are striving to create in schools, those conditions, that definition of close contact should never be met. That's not where we are. And again, to make sure we can keep schools open, we are at this point, and this may evolve as we have seen every day. COVID changes us and changes its plan for us. At this point, regardless of who in a classroom has had close contact or not, we are going to recommend testing for the entire cohort or the entire classroom, all the students and the teacher, and then any, let's say a substitute came into that class. And so while the first step is us confirming that there's a case, a lot of the times I think one of our most common scenarios is that a student or a parent of a student or a staff has been exposed to a COVID positive person. Our first public health recommendation is that person who's been exposed needs to be removed from the school environment immediately. Staff or student or teacher needs to be removed because they've had exposure. They shouldn't have come to school in the first place, but that does happen, we've seen. And that's why we have our screening questions as part of, we're encouraging parents to screen their students at home, and parents have been shared resources around screening. And we're also going to be issuing a guidebook for parents that, again, reaffirms that parents should not be sending any students to school who are sick. They should not be sending their students to school if there's any known COVID-19 exposure. But that does happen sometimes. And then if anyone does arrive either sick or with a known exposure to COVID-19, they'll be sent home and be tested. If the person tests negative, we are not going to implement contact tracing. It would not be considered the person themselves may have been exposed, but they haven't exposed anyone else to COVID-19. So that cohort would stay open. If the person tests positive, though, that's when we would close the cohort down. The only caveat to that, and this is why attendance and line lists are really important, there have been cases where someone tested positive, but they were not attending school in the time frame that would be considered their infectious period, and that's been a scenario too where we don't shut that cohort down. But if they were in school, they tested positive, we would consider everyone in that classroom or their cohort exposed, not their whole school, not the whole school, but just their cohort. And then everyone would get tested and then be placed under a quarantine. So the cohort would effectively close for 14 days from the last known exposure to COVID-19. And that's, again, that's our primary tool. So our first tool is having a lot of testing. Our second, in flattening the curve or reducing COVID-19, our first tool is having testing widely available. And that's, again, our role is making sure if we do find someone's been exposed that's in the school, part of the school community, we'll get them access to testing as quickly as possible so we can make decisions around keeping a cohort open or closed. And then our second big tool is this contact tracing. And we have a large contact tracing team. We will be, you may have seen, we have over 70 staff that are contact tracers. As we move forward into the school year, we'll also be looking at supplementing our staff that we now as a lean team of school nurses with those contact tracers. So, and because that's what allows us, again, to manage, there's a lot of schools in Marin County, and to identify anyone that may have been exposed, and then to have action to make sure that there's no additional exposure. And the actions usually would be closing the cohort, and then isolating the person who's known to be positive, and then quarantining children that are known to be exposed. The challenge will be here is that many parents, and we've seen this, once their child who's been exposed tests, we usually recommend testing 5 to 7 days after the known exposure to COVID-19. So we don't test, like, let's say a child came into a classroom and we learned they tested positive, they're removed from the classroom. We don't recommend testing everyone in the classroom the next day. Most likely there would be a lot of false negatives. We recommend everyone going home, staying home and quarantining, but then we recommend testing 5 to 7 days after the last known exposure. That gives your body enough time for the viral load to increase. So when we do test for COVID-19, we are more likely to have a true positive result. The hard part, as I was mentioning, is when parents, their child's on quarantine, their child is not sick, it's been 7 days since the last exposure, the child tests negative, and they still can't return to school. It's a very frustrating experience for families, especially working families who depend on school for childcare. This is, again, where we're working on an abundance of caution with current guidelines, is that child needs to stay at home and complete their 14-day quarantine, and the cohort needs to be closed. Again, this is a place where we have evolved. When we were starting in the spring, it seems so long ago, our original plan was 1 positive test, the entire school closes. We've learned a lot more about COVID-19 and don't feel that is necessary at all. As I mentioned, most children in a classroom, if they're following all of the protection plan guidance, they're wearing face covers, they're maintaining 6 feet distance, and that would already make them not a close contact. But we are going to test everyone out of an abundance of caution. The challenge will be for us as we go up in age groups, where into that middle school and high school levels, where we know the cohorts will be larger, because kids, it's not just one classroom that is moving through that learning environment. And we're looking at some technologies that can help us with that contact tracing part. So that's still emerging. I thought we may have more time, but we might have less time to figure that out. The technology piece of it out. We can figure out contact tracing easy. It's bread and butter for us. We have technology to support us in a system called CalConnect. And, but we also are looking at apps and technology that, that people, especially high schoolers, might be more willing to anonymously report who they might have had a close contact with. Because again, we know that our risk of exposure, and this has been consistently seen, is not in the halls of the school. It's more likely people's behavior when they leave the school campus and are not being as vigilant in not mixing with other folks. So that's where we are. So you can jump ahead on content. And so they'll share this. So they'll share this video on this presentation. And it's a longer video. I think it's around a 4-minute video Dr. Willis did on describing the science of contact tracing. So if you want to improve your competency in epidemiology, you can look at Dr. Willis's video, which is very, very well received. So I went over this a lot around a close contact. And again, just the reason why we're testing the whole cohort, because as you become more comfortable working in during COVID times and being on the school campus, you may yourself not understand why we're testing so much, since what I anticipate is that we will see a lot of negative tests in our testing, which is great. This is, again, out of an abundance of caution, but the biggest risk and what we see for transmitting COVID-19 is when you are within 6 feet of someone that's infected, you have to be there for at least 15 minutes, and you're not wearing a face cover. So you can jump ahead. So this is a lot on one slide, but we've identified 4 different scenarios, and I think this is where I don't think we have time today to run through all 4 scenarios. I kind of described some of them. Mike, I'm going to interrupt myself and ask you, do you want to run through the scenarios? I don't know how much time we have.
No, I think mainly we just wanted to point out that this is one of the most critical roles of the public health liaison is at each school is to be very familiar with these 4 scenarios. We're not going to run through them today, but each one of them has a link that if there is a communication, there's a link to the, what communication you should give to your parents, to your staff, if any at all. So I would say the best thing to do if you're assigned in this role is to really review this, ask questions. If something's not clear, let us know. Well, I imagine that we'll be continually revising and updating this as we get new guidance from public health and gain experience in utilizing this system.
And maybe what we can do, because these are kind of this is the intro to public health liaison training. If we hear back from you after you review the materials, we can see, we can have a secondary, part 2 where we run through scenarios and maybe have time for questions. So we'll hear back from you if you think. I recommend everyone just review the one-pager, review the protocols, reach back out to MCOE if you think it would benefit for you to have kind of a specific scenario-based training, but letting you know that we absolutely are ready to be on the phone with you when that first scenario happens, and we expect you probably to have the scenario handout on one page and your phone on the other hand. And then walking through of course you'd be 6 feet away from the child or staff that you're talking about. And we work through each scenario with you. So let us know if you would like a kind of a secondary training.
Can I just ask, is the best thing to do to just email or call if there's a specific question? Or,
yes.
Okay.
Email is being monitored. What we'll see on our side is if we need to have a specific phone line just specific for schools, that might be something that, again, we want to make sure we know access to us is what's going to build your confidence and competence in your role. So we'll evaluate that on our side if we need to get a kind of a backline, a hotline into our schools group. So we'll evaluate. We haven't needed it yet, but we'll evaluate that. Often what happens is we share, when the person calls, we end up sharing our cell numbers, honestly, because sometimes it's just this quick back and forth text like Mike was mentioning that helps us get through that. So that's usually what happens once we get connected on a case or an exposure, is that our goal is to be in high contact with you.
Yeah, and we pointed out too that we actually did a specific training on this exposure control protocol about a month when we first developed it, maybe 5 or 6 weeks ago. So that's taped and available on our website. We'll put a link up in the chat box as well.
Great, thank you. I forgot about that. So long ago.
Okay, we're going to hand it over to Melina Boyd, a member of our Rethinking Schools Task Force, to tell us a little bit about record keeping, because this is also a critical part of the role.
Yes. So the easy part is if you have a question about an exposure or anything like that, call public health, email public health, reach out to them immediately. The harder part about it is keeping the records. So there's basically 2 sets of data that public health can use to do their contact tracing. So there's the contact information and then attendance records as well. For both of these sets of data, you're going to want them for both the students and the staff. As far as the contact information is concerned and the attendance, you're going to kind of want to gather it per cohort or per classroom, so you know kind of who was together for whatever period of time. So we'll talk a little bit more about contact information here, and then we'll go into some examples that we use for the pop-ups and the pilots and for summer school as well. So for contact information, how do you track it? You can use a spreadsheet in Google Docs. You can use an Excel spreadsheet. You can use your attendance software so that you can gather all of that student information and emergency contact information there as well. How would you gather it? You could use Google Forms, or again, you can use your attendance software to gather that as well. For the attendance, they're going to want maybe about 10 days, school days prior. And the reason that they want to see this is because they are going to want to see the last date of known exposure. So if a student was absent, for example, for an entire week and they were not in the same classroom as the affected student, then they're not going to necessarily need to do the contact tracing for that family. And again, you can gather this information in many ways, one of which is a spreadsheet with the Google Docs, and I'll show you some examples of those as well. And then again, the attendance software like Aries or ASAP or whatever you use. So it's really good to start thinking about that and thinking about the most time efficient way to do that as well, because you're going to want to keep all of these records up to date on a daily basis. And it can be really time consuming. We were working with, maybe 16, 17, upwards of 25 different cohorts. But then when you're thinking about an entire school, it can get a little bit tedious. So it's really good to think about what is going to work the best for you so that you're getting the right information to public health in an extremely timely manner. And again, I'm just going to stress that you're going to want to try to keep this up to date on a daily basis so that if there is a known exposure, and rarely do you get that call during the day, it's usually at night, late at night, because they get that test back and it's kind of a mad scramble to get this information to public health. So keeping it up to date kind of eliminates that mad scramble. So this is what we use for a cohort tracker for our pop-up and pilots. We just used Google Drive, and we would put all of the information in there. We gathered the information from a Google survey, and it just went straight into a spreadsheet. And then we put it here per cohort so that all we would have to do is PDF this document and send that along to public health. Again, this is going to show all of the information that they're looking for that is ideal for them, including date of birth of all the students and staff, as well as the address. And again, this is going to be kind of a decision that you're going to want to make on a district or school level. So this is from Aries. All names have been changed to protect all the students. But this is pulled straight from Aries. So it just has all the contact information and it's grouped by class already. So it's a really easy way to do this. And again, you would just PDF this and send that along to public health. Next up this is an attendance tracker that we used for pop-ups and pilots that we used in Google Drive. You can see here we just put X's and this is a way for public health to kind of look back and say, like, this student wasn't in here and this was the first day that this student may have been positive. One good thing that you can do for public health that's really helpful for them is if you highlight the affected student. So you would just highlight all the way across, so it's just easy for them to do the X's. Another thing to think about is staffing. So obviously your teacher is going to be in there if you have a para, but if you have like an occupational therapist or someone like that that's coming in to work with a student one-on-one in the classroom, you're always going to want to make sure that you have all of this information. So start thinking about exactly how you're going to gather that. And then this is Aries again, and this is just kind of a weekly report for attendance. And with Aries, if there's a mark there, it means it's absent. So you would just want to let public health know when you send it along that's what that indicates, is that if there's a mark there, that means that they were absent on that day. Next up, I'm just going to talk really quickly about our liaison registration. You guys know how to contact public health, but should they find out in another way that one of the students is positive or there's some sort of exposure and they want to contact you, we just want to make sure that we have all of your contact information. So the link is on here. And then Michelle, would you mind? We're going to put the link in there. And again, there's probably, these trainings are open to more than just the actual primary and secondary liaison, because it's just good for any administrator to kind of know what's going on as far as contact and exposure is concerned. But for this registration, we want your primary and secondary, the ones that were named on your site-specific plan. So only that information would be great. And then one quick reminder, we talk about the SSSPP a lot. All schools are going to be required to have this in place before they have, before students are on campus for instruction. If you go to our website as well, the Rethinking Schools website, and we'll get that link in there in the box for you. We have 3 different forms for the site-specific plan. We have it in Adobe, we have it in Word, and we also have it in Google Sheets, so that you guys can use whichever one works best for you and is the most accessible. So that is my spiel. I think I'm going to go ahead and give it back to Mike and Lisa and just see if we have any more questions.
All right, thank you, Malia. And you just need to be able to know where to get it and how to get it to public health as soon as possible. And the other thing that I want to say is that there's going to be this nuance of, you know, the specific classroom cohort and the cohort teachers should be pretty basic. The variable will be the substitute teacher or the specialist, the one-on-one specialist, or a visiting teacher or staff member who comes in, and how to document those kind of less regular, more random visits to a classroom. We want to be able to track those people down. So that'll probably vary from a little bit from site to site, and the complexity will be a little bit higher at middle school and high school levels. So that's something that is probably best practices to be developed. But I think with that, we'll go ahead and open it up to questions.
Thanks, Mike. Thanks, Ken. Thanks, Lisa. We wouldn't be anywhere without all of your support and help. I have a couple quick clarifying questions about how the governor's new order sort of overlays this process on our thinking. And so my first question is around, in our waiver, we had a limited number of adults per cohort, and we had one of those adults we were planning on being our PE teacher. So that would be an outside class, 6 feet apart, masks. In the very unlikely event, but possibility that our PE teacher were to get sick, how would we look at track and tracing, and if he's had contacts with every class? So question 1. And then question 2 is, the governor's new order limits 2 adults to a cohort of 14 kids. How does that interact if we get a waiver approved? Is our waiver of 4 adults per cohort what we'll be able to go with? And only the grade levels that aren't covered by the waiver would we have to adhere to 2 adults, or how are we thinking about that?
I believe I have good news for you. I'm going to go with your second question first. So your TK through 6 would be operating under school operations, so not part of the new guidance from the governor. Your older grade levels would be under the youth activities guidance. We just reviewed with county council yesterday and today, and we'll be providing clarifying FAQs. If you go down the guidance, kind of like 2/3 down, they describe support service providers, and we believe that you would be able to identify, you would have 2 adults and then identify support service providers that are part of that cohort. And you would still need to track. Now, going back to the contact tracing part, you have the additional burden then of making sure the support service providers. So I was just on a phone call with the schools before. It could be a speech therapist or an attendant, assistant, whatever's needed to support the environment for the child. You would need to have tracking to ensure the contact tracing, they're part of that contact tracing. Same thing with a physical education teacher. Again, our goal would be, with a physical education teacher is a great example where ideally they are we're not identifying them as a close contact. They're maximizing their time outside, et cetera. So we would allow them to continue to return to school, monitor for symptoms, and return to school, monitor for symptoms. And if they do develop symptoms, get tested. And if they don't develop symptoms, they can continue serving in that function. Where I think I mentioned earlier, it's like we're going above and beyond. There's an abundance of caution, calling everyone in a cohort that they're close contacts, and it's more that we can't see and we don't know, especially with those younger grade levels. And so this PE teacher wouldn't have an intense 8-hour time in an indoor classroom with the same cohort. So I think it's, again, that would those folks who move and interact with different cohorts, we just need to do a strong job of educating them around their own protective habits and hygiene, and making sure that those groups also, especially because they are probably one of our greatest vulnerability, is that they are really encouraged to limit their social activities when they're outside the school environment in order to not to bring anything in, especially since they could seed in multiple different cohorts.
Thank you.
So there was a question that came up in the chat box. Do siblings also need to quarantine?
Yes, generally, yes. There would have to almost be a special circumstance where siblings are not living with each other. Typically, the exposed child, their sibling would have been exposed to. So those were the scenarios that we dealt with in some of the ones that were on the chart. And so we exclude, we would pull out the sibling who might be in another cohort. So my I test positive. I have to pull my 3rd grader and my 5th grader out of a cohort. So that's again, us erring on an abundance of caution until we know the status of the child. Often the children will remain in quarantine. The children will remain in quarantine, and they may not have to. In the scenarios we work with, we didn't have to close a cohort with siblings, but it's possible. We treat the family unit.
So there was another question that came up. Is there an opportunity for on-site training? And what I want to say is that when we first opened the pop-up childcare programs, we had 6 different sites that opened over about a 10-day period. And we had a vision for an on-site training, but as the reality of operations unfolded and the kind of contradiction in having an on-site training when we could do trainings over the phone or Zoom became apparent, we ended up doing, at least initially, kind of some weekly check-ins with public health, where the Marcia Grant, the public health nurse, would get on 1 or 2 calls a week with the team of the site liaisons, basically, and to review questions that had come up over the past week to clarify and help everyone learn from each other's questions. And so my suggestion on that is that we probably will not do site-based training, but we'll continue to have opportunities like this as we learn and grow from our experience.
Yeah, and just to add to that, we have not made a final decision yet. So public health officer review of the site specific protection plans was required for the waiver. We are considering offering this for all schools. I have to talk to Linda Metz, who's on the phone call tomorrow, because at this point, all schools in Marin County should have a site specific protection plan. School has started, they should all have been developed. And they could be updated, and it shouldn't just have been for the waiver. So we encourage everyone on the phone should see that site-specific plan, make sure it's been done. My assumption is that it's school, so everything was done on time and everyone's done their site-specific protection plan. In our review of it, when Matt and I both reviewed them, we just saw what a good exercise it was for the school leadership to go through that process and answer all the questions that are in that 30-point guidance and take it to that local school level, school site level. So that is the key. And talk to your administrator if that plan's not done yet, because it should be done already.
There's a question here, Lisa, about how long is it currently taking to get test results back?
Right now, if you test with color, it's within usually a day, less than 24 hours. If you're testing on average with Kaiser, Quest, et cetera, we're seeing around a 2+ day turnaround. It is not where we were in the middle of July, where it was unacceptable where we were in July. And I know probably some of you on the phone call felt the pain of having more than 14 days go by from a test done. And to us, we absolutely think that's unacceptable. As I mentioned earlier, testing is our first tool, contact tracing is our second tool. We can't contact trace effectively if we don't get results immediately. That being said, again, we'll be looking at emerging technologies to make sure we have access, as always, to the best technology so we can keep improving our ability to screen and have rapid testing turnaround. And this is where I've never in my career have seen such a rapid emergence of technology. The benefit of it is it's rapid and emerging. The downside of it is we don't know if we jump on the wrong horse and the best application of each emerging laboratory technology that's available to us. But that's something Dr. Willis and I are just firmly committed to, that making sure Marin County has access to the best, all primarily driven by my selfish desire to get schools open safely and keep schools open. And we were on another call, we had no outbreaks, and my goal is 0 outbreaks in the school setting, and that depends on our partnership together. So.
Thank you, Lisa. There's a question here about families who, for many reasons, don't want to get tested.
Families don't want to get tested.
Well, yeah, like so let's say that there's a cohort with a COVID positive teacher or student, and the protocol would be to get everyone tested, and there's a family for whatever reason who don't want their child to be tested.
It's actually a different scenario that I was talking about, Mike, which is like, hi, Lisa, which is the kid shows symptoms, but the question is, or the parent shows symptoms but doesn't get tested. So the answer would be no, I don't live with somebody who has a COVID positive test, but the symptoms of that person are COVID positive.
And this is, again, I'm going to be reviewing, we have our final handbook to get out and see the light of day, and it's been delayed. I'm going to be reviewing with pediatricians where, just to confirm it, it's what's driving COVID, what should be driving COVID testing is known settings with COVID for testing. And it's a significant burden. Again, our approach is erring on the side of caution, but we're going to be hopefully in the next week, after review by the county's pediatricians and family physicians, providing more clear guidance around who needs to be tested to return to school, who doesn't need to be tested to return to school. And it's just so complicated because COVID looks like so many different things. So we'll have more clarity there. And then around the household testing, I'm not so concerned about it in the sense that that household and those students wouldn't be allowed to come back to school. So they would be on a quarantine, they don't get tested, they're on a quarantine for 14 days, they don't come back to school. Even if they were COVID positive, they would be past their own infectious period upon their return to school. So it's okay if families refuse testing, they just wouldn't be allowed. Well, they wouldn't be allowed back into the classroom anyway. It would be beneficial for them to know if they tested positive or not. So, but that's their choice. We have choice in our community. It made me think of another thing, and just to reiterate, in the scenarios that we saw, most of the COVID positive people, especially children, were asymptomatic or very mild symptoms for one day. And so that's the challenge of COVID-19. It's what is the same thing, that the nature of this disease not yielding a tremendous productive cough in kids and sneezing in kids that's long lasting, especially in that under 10-year-old population, is why they're less likely to be vectors like they are with flu. There's a big difference between flu and COVID in children, especially children under 10, where children are known vectors and transmitters of flu to adults. That is not, research consistently is showing that that's not the case with COVID-19. But it will be frustrating for everyone because we're going to have relatively healthy children that are going to be staying at home. But that's where we are with our relationship with COVID as a newly emerged virus. And that will be a frustrating part because someone that was with the flu is going to be able to come back much sooner and potentially not be as well as the other child. But that's, again, where we are with knowing what we know today about COVID-19, which may change early in 2021. So
there's a question, Lisa, from one of our special ed staff who, really is kind of the keeper of the data. and understands that probably our special education program manager and director will want to be the official public health liaisons, but is asking, who should register. I think the way the guidelines are written is there needs to be a primary and secondary at each school. Could there be a third person who who could be kind of the keeper of the data?
Absolutely, and we're more than happy to manage that. And that's how it happens with us. We find we like the most obsessive compulsive spreadsheet lover. So whoever that is, we'll be happy to talk to the administrator. But the person that is going to help us and probably is best, who knows those classrooms, because they just see spreadsheets. That's what they dream in. Those are our favorite folks. So we know the administrators are decision makers and respect that. But absolutely, there can be 3 folks listed, and having that backup is helpful because, again, we're in a pandemic. Don't forget, this is a pandemic. We're going into a flu season, and someone might be out sick, maybe not with COVID, but flu or some other condition like the virus my kids had. So it's always good to have redundancy and have more than, I think having 3 people deep is the ideal, honestly.
That's great. So, there's a question about the middle school and high school level, where you have specialist teachers teaching science or math. And this is where you have a larger cohort made up of multiple classrooms. And the scenario, they're saying if a math teacher tests positive and the kids went to different classes, does the science teacher, if there's a teacher who's been working with multiple classrooms, does everybody quarantine?
Not if we're good with testing and we are good with contact tracing, the most likely scenario is that we would quarantine all the students who were in the class with the teacher, but that 3rd degree risk where the student then went to another class, they went to art, and we wouldn't quarantine the art class. Unless the student tested positive and we determined they were infectious while they were with the art class. That's why, again, why we have been successful is because people have been reporting when they've had COVID exposure. We've had access to testing, and we effectively nipped this in the bud, but it really depends on people being forthright with revealing their COVID status, and being honest with themselves about their own potential risk and whether they really should, if they're having symptoms like an itchy throat, and because they went to a wedding last weekend, they really should get tested for COVID-19. And I think that's going to be our risk again. I think when schools come back online, people in the first month will be vigilant. And then our human nature is we regress to not being vigilant, and our behaviors just naturally slip. So, and again, there's also the virus is at fault. It's not just human fault. The virus behaves in our community and can increase in its circulation. There's mutations and other things that change the nature of how it's circulating in our community, and also how severely the outcomes of its circulation is. We have, the other reassuring thing for you to know is we have the lowest per capita hospitalization rate in the state, or in the Bay Area. So we're not seeing high levels of hospitalizations compared to other communities.
Okay, so I know we're nearing the end of our time, and we're not going to be able to get all the questions, but what we'll do is we'll take the questions out of the chat and make sure to fold them into our next training a week from today. But we have maybe the opportunity for 1 or 2 more. There's a question about private independent parochial schools, covering being responsible for their own testing. Can you address that?
So there's new law that's been clarified where healthcare plans are responsible for testing staff. So this is where there is confusion again, where guidance from the CDC changed, saying that did not include essential worker testing. The California Department of Public Health came out right quick, followed by Marin County, saying that is not our recommendation. We have, for our guidance, that essential workers, so in the school setting, we are requiring testing every 2 months for essential workers. Our understanding of the law is that healthcare providers, healthcare plans, managed care plans need to provide that testing. It's a space that's evolving, and testing again is one of our critical tools. So there should be access to testing for staff through their regular provider. We've worked with private schools already where they are contracting with additional providers, and we see ourselves in public health in supporting public schools with testing. It's getting, and that's where we're trying to find the most cost-effective testing. Testing is available. We could test everyone, but it's $100 a pop. And for a public school system, that's a lot of money. So we're working actively this week and into the next week just to make sure we can really make it as simple and easy as possible for people to access testing, and to clarify what your healthcare plan should be doing for your staff, because they are school staff considered essential workers who should qualify for screening testing as required by California state law.
Okay, thank you, Lisa. So maybe we'll make this the last one. If a family travels out of state or out of the country, do they have to be tested before they come back to school?
No, that changed too. So the CDC just changed there was a requirement for quarantine from international travel. That's been removed. So the 14-day quarantine for international travel has been removed. And there's no, in the state of California at this point, it's different in other states, we have no quarantine requirement. We would say if someone did travel and then was known to be exposed to COVID-19, they do need to be tested. And that, honestly, those are the most common scenarios we're seeing, is that people go to family gatherings. They find out after they come back from the family gathering or friend gathering that's, oh, someone from the gathering tested positive. They get tested and then they test positive. So that's when people are less vigilant about physical distancing, wearing their face covers. It's our natural human tendency to socialize. We naturally don't like to wash our hands, and we naturally like to socialize. And so that's what we're fighting with.
Okay, well, thank you so much, Dr. Santoro. We're going to leave it at that for today. And please know that we'll try to capture the questions we couldn't get to today and incorporate them into the training next week. It'll be Thursday the 3rd at 3:30, and we'll be able to include anyone who wasn't able to come today. We'll try to get a bigger Zoom capacity room. But thank you so much for everyone, your participation today. Lisa, thank you to you and your team for all that you're doing. And we know that this is a new and critical role that will help our schools moving forward into this most unusual school year. So thank you all for being here, and we'll see you next time.